कर हो गया जल्दी
3,
कराओ
2, 1. Dr. Faisal, unmute yourself. Unmute yourself first.
Welcome, everybody. My name is Dr. Faisal Mehmood. I'm an infectious disease specialist, head of ID at Afan University. We're very happy to have you here with us today. Our session today is going to be a little different from the normal ones we've had about COVID-19. As you know, COVID has been with us for the last 3 months or so, and we've seen a lot of guidance and guidelines coming out in terms of how to manage patients, especially in the healthcare facilities, how to manage sicker patients, patients who require oxygen or ventilators. However, we do now know also that a number of patients are not so sick and can be managed at home. And there are a number of reasons for this. First of all, patients may not find beds at home to take care in the hospital, to be taken care of. And also, healthcare workers can manage most cases at home until or unless they get sick enough to come to the hospital. So, with this, I'm going to ask Dr. Mehreen and Dr. Danish to introduce themselves and start the session. And we'll be going over some of the guidelines that we have developed on how to manage COVID-19, particularly in the outpatient setting or at home. And then we'll open up for questions. Dr. Mehreen, on to you. Thank you.
Assalamu alaikum, everyone. Thank you so much for being here today. I'm really excited to talk through these guidelines today. I am Mehreen Arshad, as Dr. Faisal mentioned. I am a physician in the US. I am a pediatric infectious disease specialist, and I work at Northwestern University in Chicago. We've seen a number of COVID-19 cases, and so I have, experience with working with both pediatrics as well as young adults who have had COVID. Dr. Danish.
Assalamu alaikum. My name is Dr. Danish Siddiq. I am an infectious disease internal medicine doctor in Tampa, Florida, also in the US. I have both worked in infectious disease, and I still do primary care and internal medicine as an outpatient. So I had a lot of reasons to be involved in this, because I wanted to make sure that we had evidence-based guidelines to how to deal with patients in the outpatient setting. As Dr. Faisal and Dr. Mehreen already mentioned, that there is majority of these patients can be dealt with at home and outside the inpatient setting, and with resources being limited, I think that's the best way to go. So without further ado, Dr. Arshad, you can continue.
All right, so I will start the session, talking a little bit about the guidelines, and then hand it off to Dr. Danish. So the main objective of these guidelines are to basically provide some guidance to the general practitioners to recognize COVID-19 in a febrile patient, and then to manage patients with mild illness at home. We also hope to provide some guidance on how to triage patients who may be moderately or severely sick with COVID-19. And then if there isn't any bed space available, or if the patient is getting sicker but has not been able to go to the hospital, then we provide just very brief guidelines on what to do while waiting for the patient to be admitted into the hospital. So the rationale on developing these guidelines was, as Dr. Faisal had mentioned, that in Pakistan, there's been a high number of cases of COVID-19 that have been increasing over the last several months now, and it is important for GPs to be able to triage and manage these patients at home as much as possible, because the hospital beds can get filled very quickly, and emergency rooms can be filled very quickly, and so it is important to keep those beds open for moderately to severely sick patients, so that they are the ones who require hospitalization can actually be attended to. And then families of patients with COVID-19 who also need to be kept safe. And so we will talk a little bit about the home isolation recommendations as well. The OPD guidelines on how to safely see patients in the outpatient department have already been published and are available on the Government of Pakistan website for COVID-19 guidelines. But I just wanted to go over them really quick over here, because one of the main things that we want to recommend is that as a GP, when you're seeing patients with COVID-19, you really have to protect yourself as well. And it's in a time where COVID-19 is so prevalent in the community, basically you have to pretend that every patient you see is COVID-19 and protect yourself in that way. So as I said, a lot of these guidelines are already available on the Government of Pakistan website, and I encourage you to go there and look them up. These include guidelines on guidelines for working of outdoor patient departments, primary healthcare settings in the wake of COVID-19, and there's also more guidelines on donning and doffing of PPE in OPD that are available over there. But briefly, clinicians and other healthcare workers, staff should remember the importance of hand hygiene and to make sure that the environment is decontaminated between patients with whatever available resources you have. So you can use alcohol-based hand rub, those that have greater than 60% ethanol or 70% isopropanol before seeing each patient, and then preferably wash hands with soap and water for 20 seconds between examining patients. Also, commonly used surfaces such as examination tables, chairs, doorknobs should all be disinfected on a regular basis with hospital-grade disinfectant. Clinician, staff, patients, and any family member should all wear masks in the clinic at all times. Ideally, only the patient, especially if it's an adult, only the patient should come into the clinic, and any family member should wait outside. And if that is not possible, you do want to make sure that everyone is wearing a mask. Clinic should ideally be in a well-ventilated space. So we know that when inside buildings where there are that are cramped, that do not have a lot of air circulation, the chances of infection go up. And so if it is possible to have a clinic outside, that's great. Otherwise, please make sure that the doors, windows are open, and that there is air circulating inside the clinic as well. The case definition of COVID-19 is at least 2 cases of the following symptoms. So fever, it could be measured or subjective, so measured by a thermometer, or the patient feels febrile, chills, rigors, myalgia, headache, sore throat, and the new olfactory and taste disorder. So sometimes people just can't taste anything or have no smell at all. Or at least one of the following symptoms: cough, shortness of breath, or difficulty breathing, or severe respiratory illness with at least one of the following, that is clinical or radiographic evidence of pneumonia or acute respiratory distress syndrome, and no other alternative or more likely diagnosis. So when you see a patient with fever in your clinic in this at this time of COVID, obviously you want to think about COVID-19, but in Pakistan there are other and around the world, obviously there are other infectious diseases that can also cause fever and can give some of the same symptoms as COVID-19. So the differential diagnosis that you do want to think about when you see a febrile patient include community-acquired pneumonia. These patients are more likely to have more of a purulent cough, and so a lot of sputum might come out, and then they're less likely to have myalgia and the loss of smell. And the workup that you want to do, if you're sort of thinking about this, is blood culture, chest x-ray, which will show a focal consolidation, and sputum culture. Other things to think about is typhoid. These patients might have more of an abdominal pain, and you want to do a blood culture for that. Malaria, which will show an possible anemia on a CBC, and then you want to do a CBC plus and thick and thin smear for malaria. Other viral illnesses, we don't have flu circulating right now, but soon in a couple of months, flu will also start to come up, and so it is difficult to differentiate COVID-19, especially mild disease, from other viral respiratory illnesses. But it is something to keep in mind. And in other diseases like dengue, might have. If it's mild symptoms, it can look like COVID-19, and TB, which is looks very different, but sometimes you do want to just think about it. But those patients with TB are more likely to have a chronic cough, so the cough will go on for longer. They can have weight loss, night sweats, and some of the other symptoms. All right, so initial evaluation. So if a patient walks into your room, walks into your clinic, and the first thing you want to do is check the respiratory rate, do a pulse ox, and examine the patient. If the patient has any of the following, so if they have extreme difficulty breathing, are unable to finish sentences, their oxygen saturation is less than 90%, they have a respiratory rate that is greater than 30, or they have blue colored lips, tongue, face, fingers, and hands, have severe persistent chest pain, are feeling lightheaded or dizzy, altered mentation, so you talk to them and they're not able to answer questions appropriately, or have seizures, they need to be sent to the nearest hospital immediately, because these are very sick patients. You do not have to wait and think if they have COVID-19 or anything. They may, but they may have other illnesses as well. But these are the patients that immediately need to be sent to the nearest emergency room or hospital. If you have a patient that does not need immediate hospitalization, so they're not as sick as on the previous slide, then you want to go down sort of your usual history and physical examination pathway. You do want to look for high-risk conditions. This is for adults, and those high-risk conditions include age greater than 65 years. This is probably this and underlying lung disorders are probably the most common risk factors for COVID-19 and for worse symptoms of COVID-19. So you do want to make sure that you are screening for these high-risk conditions. Other high-risk conditions include congestive heart disease, diabetes, especially if it's uncontrolled, patients who are on dialysis and have end-stage renal disease, liver cirrhosis, morbid obesity, pregnancy. We'll talk about this a little bit right at the end. And then active malignancy, or if patients who are immunocompromised. You also want to make sure that you evaluate for exposures. So ask about contact with someone with COVID-19 in the last 2 to 3 weeks. Ask if they're living in a home or neighborhood where COVID-19 is spreading, and then ask for high-risk exposure. So we know that people like healthcare workers, physicians, nurses, and paramedics, they are going to be at higher risk because they're coming into contact with other patients with COVID-19. You also want to ask about the occupation and the kind of work that they do. So if they're working in crowded indoor areas, like if they're working in the factory, or if they're working in a restaurant setting, or any place where there's lots of people in a crowded area, that increases the risk of them getting COVID-19. Residents who live in long-term care facilities like nursing homes are also at higher risk, and so are younger adults and older teens that may live in places like hostels, in colleges, because again lots of people living together. So you want to ask about all of these exposures as well, and that's important to know about the risk of the patient, but then also to understand how many people, if this patient becomes positive, how many people they might have infected. And so, for contact tracing and for sort of reaching out to these people to make sure that they isolate themselves and are looking out for their symptoms, it is very important to know who else the patient may have come into contact with. So the disease severity classification has been, we've talked about this before, but I just wanted to go over it again. Mild disease, more than about 75 to 80% of patients will have mild disease, and that is obviously higher in younger age group, and in the older age group tends to have more severe disease. But the mild disease is basically defined as presence or symptoms that are consistent with COVID, but without any hemodynamic compromise, need for oxygen, or chest X-ray findings. Their oxygen saturation in this group is usually above 94%, so it's pretty much normal. In moderate disease, patients can have hypoxia, so their oxygen saturation will be less than 94, but greater than 90%. Or their chest X-ray, they may have chest X-ray with infiltrates involving less than 50% of the lung fields. And then they may, but at this point, they usually have no complication and manifestations that are related to severe condition. In severe condition, adults will show signs of pneumonia, fever, cough, plus any of the following. So they may have a respiratory rate of greater than 30, severe respiratory distress, oxygen saturation that is less than 90% of room air, and chest X-ray that involves greater than 50% of the lung fields. So when you talk about testing, COVID-19 testing is recommended. So if you have a patient where you have a high suspicion of COVID-19, we recommend doing a PCR if the patient fits the case definition that we mentioned earlier. And then if it's mild disease, you don't really have to do any other testing. But if it's a patient that is, say high risk, or you're sort of worried may go from mild to moderately severe, there are some additional tests that you can consider. That includes a CBC with white blood cell count differential, and that may show a lymphopenia. So the lymphocyte count may be low, and that is associated with a more severe disease. So that may sort of give you a clue that the patient may go from mild to moderately severe disease. You can also do a BUN creatinine electrolyte liver enzymes, and that may show elevated creatinine or elevated liver enzymes that may, that again sort of points towards multi-organ involvement, and if these are elevated, you may want to keep a closer eye on these patients. A CRP may also help, especially if you have a patient that is sort of slowly getting worse, or you're seeing them over a number of different times. Then a CRP, especially if it's increasing over several days, can suggest that the patient may be getting sicker and may be heading towards sort of a more severe illness. If you do a chest X-ray, that will show bilateral hazy infiltrates that is similar to other viral illnesses. In the outpatient setting, we recommend against getting LDH, D-dimer, IL-6, ferritin, because these are, one, they're expensive tests, and second, there isn't really any use of them in the outpatient setting, because we would not we wouldn't treat any of these lab tests. So just a brief overview of management of mild illness. So you want to, if you have a patient with mild illness, and we'll talk a little bit more in detail in the next few slides about these as well. But just as an overview, if you have a patient with mild illness, you can ask them to use paracetamol for fever. There is no indication for use of any antibiotics or anticoagulants in mild illness in the outpatient setting. There is also no role of steroids in mild illness, and we'll talk about that in a little bit. You do want to tell the patient and their family to make sure that they're isolating at home, and we'll talk about that. And then any of the caregivers need to wear masks and gloves when they're caring for patients. If the patient can afford a pulse ox, they can get a pulse ox for themselves and monitor their oxygen levels at home. And then you want to make sure that you are telling the patient to come back to the OPD and come back to your clinic if their symptoms worsen. And there are multiple ways. You can either give them a number to call. You can give them, if there's telehealth that they have access to, they can do that. But you want to make sure that these patients know when to come back into the clinic and when to follow up with you. All right, so medications that can be used in mild disease. So these include medications that can be used for fever reduction, and that's paracetamol. There is a theoretical risk associated with NSAIDs like ibuprofen or naproxen, because it is thought that the SARS-CoV-2 virus enters the cell, enters the lung through the ACE2 the ACE2 receptors in the lung. And the ibuprofen and NSAIDs like ibuprofen upregulate, so they increase the number of those ACE2 receptors, and so that theoretically that might increase the risk of severe disease, but there isn't really strong data one way or the other. So if they absolutely have to use an NSAID, that's probably okay, but we recommend using paracetamol just because of that hypothetical risk. The patients can also use antihistamines or other decongestants. This can be taken for cough and congestion. Then oral hydration. So especially if the patient is having GI symptoms, so if they're having diarrhea, if they're having vomiting, that can also happen in COVID, they can take oral hydration. Medications that should not be used in mild disease and in the outpatient setting. So antimicrobials, there really is no roles. In the beginning of COVID, there was a lot of hype about hydroxychloroquine. There was a lot of hype about azithromycin, and then later ivermectin. But really, none of these, none of these drugs have shown any effect on COVID in multiple studies. So hydroxychloroquine and azithromycin, as you know, has So hydroxychloroquine and azithromycin has been studied in the US, around the world. There have been multiple different trials and have not really shown any effect in patients with COVID-19. The ivermectin, there are some in vitro studies, so there's some lab-based studies that show that ivermectin may have an effect against SARS-CoV-2. But it is important to realize that the dose that they were using in the lab setting was 10 times the dose that we normally give to humans. So it's ivermectin has really no proven benefit in patients with COVID-19. Antibiotics, just in general, doxycycline, cephalosporins, penicillins, anything. Fluoroquinolones, I've heard a lot of people use fluoroquinolones. There really is no role for any of these antibiotics in management of COVID-19. One, because we know that antibiotics do not work against viral infections, and secondly, because the especially in mild illness, co-infection or superinfection with bacteria are very, 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 very uncommon. They do sometimes happen in the inpatient setting when patients are more severely ill, or if they're on a ventilator, and antibiotics have been used and are used in those settings. But in the outpatient setting, there's absolutely no reason to use antibiotics. In fact, overuse of antibiotics can actually lead to a higher rates of antibiotic resistance in the community. So you want to be very, very careful about not using antibiotics. Similarly, for steroids, steroids have been, and are being used in the more sort of moderate to severely ill category of patients. However, if you use them too early in the disease, so if you use them when the patient has mild disease, theoretically there is a risk that because again, steroids reduce the immunity. So if you reduce the immunity, there you can actually increase the viral load of SARS-CoV-2 in these patients, and theoretically there is a risk for having worse outcome if you use steroids early on in the disease. Herbal medications such as senamaki and all, a lot of patients are using this, but again, just remember that there are side effects associated with it, and patients have been admitted into the hospital with these side effects, so they don't get COVID, but they have side effects from these herbal medications. And those side effects can include anything from diarrhea, cramps, dehydration. So you want to make sure that patients are not are avoiding that as well. And then IV fluids. It can actually be detrimental. I know a lot of people, IV fluids are used very frequently in some outpatient settings, but you just want to make sure that fluid overload. If you give too much fluid, especially if you give too much IV fluids to these patients, these fluids can actually go into the lung and cause worse outcomes in COVID-19. So if you're suspecting somebody with COVID-19, I would suggest staying away from IV fluids and just letting the patient take oral fluids and maintain the hydration. Dr. Danish, do you want to take over?
Sure. Thank you, Dr. Arshad. So अब हम बात करेंगे about isolating people at home. कि घर पे आप अगर एक शख्स को infection है और बाकी लोगों को infection नहीं है, how you keep them separate so that you prevent the spread of disease, ताकि घर में बीमारी फैले ना. So सबसे important चीज़ है कि अगर आप अलग कमरे रख सकते हैं, if the person who has the disease can stay in a different room, a different bedroom and a different bathroom, that is the best way to deal with it. और घर में अगर जो शख्स बीमार है, if they want to be taken care of, if they can take care of themselves, so the person who's taking care of them should be someone who themselves is low risk. So उनकी उम्र 65 से ज़्यादा नहीं होनी चाहिए. They shouldn't have lung problems. Preferably someone relatively young at home should be taking care of that. And उनसे भी उनका कांटेक्ट का जितना कम रह सके वो बेहतर है. तो जब वो जाएं उनके कमरे में, तो फिर भी जितनी चीजों में मदद करनी है कर लें, लेकिन बाकी बाहर आ जाएं. जब कमरे में हो तो मास्क जरूर पहने. As long as you're wearing a mask, there's very good data coming out that just masking between the patient and the caregiver in household contacts has reduced transmission by up to 70%. So wearing a mask, if there is one thing I can harp on in this presentation, is as a general practitioner, you're on the front line and you're the ones who are counseling patients and families, and you're seeing majority of the patients. If you can convince people, even if they don't have COVID nowadays, to wear a mask or just cover their face and mouth in this area with a cloth covering, you can significantly reduce the risk of transmitting the disease. अगर आप कमरे में जा रहे हैं तो उस वक्त भी इनकरेज करें कि मरीज भी मास्क पहन ले, अनलेस के वो उनके लिए सांस लेना बहुत मुश्किल है। लेकिन जो ख्याल रख रहा है मरीज का और जो मरीज खुद है, दोनों बोथ ऑफ देम शुड बी वेयरिंग अ मास्क। सो इफ यू कैन नॉट have different rooms, अगर अलग अलग कमरों में नहीं रख सकते आप लोगों को, then you should try and keep the windows open if possible. Obviously बारिशें शुरू हो गई हैं वहाँ पे, so you have to be careful of mosquitoes as well and mosquito borne illnesses like malaria. So if you're opening your windows, you should preferably try to sleep behind mosquito nets if possible, and keep the bed 6 feet apart if you're sharing a room. अगर एक ही बिस्तर में लोग सो रहे हैं तो there is something called head to toe, के तकिए दोनों अलग साइड पे रखें बिस्तर के, keep them on separate ends so the head are where the feet of the other person are. And common sense practices, if you're going to put a fan in the room, it should be on the side of the person who's healthy, so the air is blowing from the healthy person to the unhealthy person and not the other way around. बाथरूम का इस्तेमाल जहां तक है, आइडियली अगर अलग बाथरूम इस्तेमाल कर सकते हैं तो करें, अगर नहीं कर सकते तो जो बीमार शख्स है अगर वो साफ कर दे हैंडल्स, फॉसेट्स, डोर नॉब्स, फ्लश का हैंडल, उस तरह की चीजों को अगर आप ब्लीच की वाइप से साफ कर दें या साबुन के पानी और टिश्यू पेपर से भी साफ कर दें, तो ये वायरस बहुत आराम से मर जाता है। दिस इज नॉट अ वेरी रेजिस्टेंट वायरस टू डिटर्जेंट्स और सोप्स। तो अनलेस लोगों के कपड़े या सोइल्ड के किसी ने उल्टी कर दी है या डायरिया से स्टेन्ड कपड़े हैं, तो आपको कपड़े अलग धोने की जरूरत नहीं है। अगर लोग कपड़े घर में साफ धोते हैं तो दैट्स फाइन, अनलेस द क्लोथिंग इज हेवीली सोइल्ड। तो अब ये सवाल फिर आ जाता है कि you have someone who has COVID-19, how do you stop isolation? किसी शख्स को आपने आइसोलेशन में घर में रखा हुआ है कि वो कब आ सकता है आइसोलेशन से बाहर? So just going back, this is based on the CDC guidelines that we use here. दो तरह के मरीज होते हैं, majority जो आप लोग देखेंगे they'll have symptoms, and when the symptoms start, ideally 10 days should have passed since their symptoms start, और उसके बाद they should have had at least 3 days या 72 घंटे of where their fever should have completely resolved without taking any paracetamol or any medication to reduce fever, and improvement in their respiratory symptoms, कि उनकी खांसी बेहतर हो गई हो, बलगम ज्यादा ना आ रहा हो, सांस ज्यादा ना चढ़ रही हो. There is good evidence that after these 10 days that there is very low likelihood that they are sick. New data is coming out कि अगर कोई बहुत बीमार है, आपका कोई मरीज ICU में चला जाता है और या वो वेंटिलेटर पे होता है, अगर वो घर आ जाते हैं, the maximum they have seen someone being infectious is up to 20 to 21 days. So अगर आपका कोई पेशेंट हॉस्पिटल में एडमिट है और फिर वापस आपके पास आता है हॉस्पिटल के बाद फॉलोअप के लिए, उन लोगों को मैं फिर भी कहूंगा कि अगर आप घर पे रख रहे हैं तो 20 दिन तक कम से कम उनको आइसोलेशन में रखें, वरना बाकी जो माइल्ड डिजीज वाले लोग, जो जैसे डॉक्टर अरशद ने मेंशन किया था, they can be let out of isolation in 10 days with 72 hours of lack of symptoms or improved symptoms. Then ये दूसरा scenario आ जाता है, which is less likely that you'll be seeing, is if someone has no symptoms. कि आप किसी को टेस्ट क्यों करेंगे अगर उनके symptoms नहीं होंगे, लेकिन ये usually healthcare workers में होता है या कहीं screening होता है, किसी की exposure हो गया है तो वो टेस्ट होता है, से उनका टेस्ट पॉजिटिव आ जाता है. Now यहाँ पे थोड़ा ट्रिकी हो जाता है, अगर इन लोगों को पूरी बीमारी के दौरान कोई सिम्टम ही ना हो, then you go from 10 days from the first test positive, कि आपका टेस्ट जिस दिन पॉजिटिव था उसके बाद 10 दिन तक you should maintain isolation. But समझें कि बीच में उनको सिम्टम शुरू हो जाते हैं, तो their clock starts again at that point, कि जब उनके सिम्टम शुरू होते हैं 10 दिन वहां से शुरू होंगे, वहां से भी जिस पॉइंट पे आपने उनका टेस्ट किया था. So basically, if they develop symptoms, you go to the strategy जो ऊपर है, which is the test-based strategy. If they don't have symptoms, then 10 days के लगभग पे you should be fine in taking them out of isolation. So यहाँ पे I would like to plug a colleague of ours who's been making very helpful educational materials. ये उर्दू में भी available है और English में भी, जहाँ पे they're talking about management of mild disease at home. I don't know, Dr. Arshad, do you want to play this during the presentation?
No, I was just, we can go for it. I just wanted
okay,
to.
So
इसका
link जो है इस वीडियो में available होगा, तो this is good information for you and for your patients. आजकल हर एक के पास स्मार्टफोन होता है और यूट्यूब हर एक जा सकता है उस पर, तो उनको आप ये दे सकते हैं. दिस इज गोइंग टू reinforce all the things that you'd be educating them in clinic about. So अब बात आ जाती है pulse ox monitoring की. We had a lot of debate about this as to ये किस situation में हो सकता है. एक चीज, अगर आपका कोई मरीज ऑक्सीजन पे है घर पे, तो सबको pulse ox monitoring पे होना चाहिए. There is absolutely no justification of having people at home on oxygen related to COVID disease where you have no way of objectively monitoring how they're doing. So if someone is safe to stay at home and you can come up with a plan with the patient कि आप उनसे बात करें कि this is like a vital sign, and we've considered this a vital sign in these patients because it can help predict which way they're going to go. Again, if their oxygen saturations are staying stable, most of the times उनको आपको वापस आके देखने की जरूरत नहीं है. आप फोन पे उनसे बात कर सकते हैं, आप टेलीहेल्थ विजिट कर सकते हैं, and hopefully inshallah they'll be fine just with time. Then the key thing is, if you're going to do this with a patient, you have to spend time with the patient. You have to sit down with them and explain to them how these machines work and how to take readings. For you to have an objective measure, ये आपके काम सिर्फ तब आएगा जब मरीज जो है वो ये, जैसे आप शुगर लिख के लाता है मरीज क्लिनिक में, वैसे अगर ये लिख के लाएगा और आपके पास ये इन्फॉर्मेशन होगी, then it would help you decide how to proceed further. So just as a baseline, we just wanted to show pulse oximeter का सही इस्तेमाल किस तरह होना चाहिए. अगर मरीज आपकी क्लिनिक में आया है तो ideally first you should make sure that he's been in a seated position, और अगर ज्यादा बीमार है तो लेटा हुआ हो 5 से 10 मिनट तक के लिए, ताकि उसकी सांस ना चढ़ी हुई हो ज्यादा. After that, obviously you need to make sure that your pulse ox is working, the batteries are running. You put it on their finger and turn it on. I think यहाँ पे सबसे बड़ा मसला ये होता है कि लोग इंतजार नहीं करते ज्यादा देर. So तकरीबन 1 मिनट तक ये आपको ऑन रखना होता है, and then once you keep it on, you see 2 numbers on the actual pulse ox. One is the oxygen saturation, which is what you're looking at, which is usually the bigger number. ये ज़्यादा बड़े अशार में नजर आ रहा होता है आपको. And the other one is the heart rate. So we want to keep things simple for the patient. ज़्यादा मुश्किल ना क्रिएट करें मरीज के लिए. Heart rate डॉक्यूमेंट करने को ना कहें, सिर्फ ऑक्सीजन कहें. और साइड में यूजुअली बार्स होती हैं जो ऊपर नीचे जा रही होती हैं, वो जो कि पल्स का वेव फॉर्म डिटेक्ट कर रही होती हैं. ये वेव फॉर्म अगर किसी के हाथ बहुत ठंडे हैं या बहुत सीवियर डिजीज है तो कभी कभी ये वेव फॉर्म नहीं आता. ऑब्वियसली अगर ऐसी कोई बात है तो उस मरीज को आपको फौरन हॉस्पिटल भेज देना चाहिए. बट इफ यू गेट अ गुड वेव फॉर्म, जो आपका स्टेबल नंबर आ रहा है, दैट इज द नंबर दैट यू डॉक्यूमेंट, एंड दैट इज योर ऑक्सीजन सैचुरेशन. कोविड-19 मरीजों में जब जो हमने डिस्टिंक्शन किया ऑफ माइल्ड, मॉडरेट, सीवियर डिजीज की, यूजुअली एनीवन ओवर 94% you're pretty safe, it's mild disease and they can monitor this level at home. चंद चीजें होती हैं जो कि कैन गिव यू फॉल्स रीडिंग्स. मेहंदी लगी हुई है, अगर नेल पॉलिश है खातन में, तो यू कैन एक्चुअली गेट अ फॉल्सली लो रीडिंग, एंड इससे गुरेज करना चाहिए. एंड यू शुड टेल देम कि अगर ये है तो कम से कम जब तक वो बीमार हैं तो इस तरह की चीज ना इस्तेमाल करें, और कोशिश करें कि जब घर पे मेजर कर रहे हैं कि दैट दे डोंट हैव दिस ऑन. So यहाँ पे again there is this YouTube video of another colleague of ours who's a critical care doctor. His name is Dr. Majid Shafiq, and he has almost a 2.5-3 minute video where he shows how to properly use a pulse ox. और ये उर्दू में उन्होंने किया हुआ है. अगर आप YouTube पे सर्च करेंगे how to use a pulse oximeter in Urdu or Hindi, then they will give you काफी वीडियो आती हैं एक्चुअली, बट इफ यू लुक फॉर डॉक्टर माजिद शफीक यू शुड बी एबल टू सी इट. एंड ये राइट साइड पे यू कैन एक्चुअली सी व्हाट यू एक्सपेक्ट अ पेशेंट टू डॉक्यूमेंट, कि आप दिन का वक्त लिख लें, टाइम लिख लें, और आपने अपनी ऑक्सीजन कितनी दफा चेक की है. आइडियली अगर आपकी सांस चढ़ रही है, अगर आपकी तबीयत खराब हो रही है, तो यू शुड टेल देम टू चेक इट इमीडिएटली एंड पुट इट. देयर इज नो maximum or minimum times in a day. If someone is stable and they're not having a lot of symptoms, every 4 to 6 hours in a day should be enough. But अगर किसी की हालत खराब हो रही है, सांस ज्यादा चढ़नी शुरू हो रही है, तो they should monitor it much more frequently. फिर फॉलोअप की बात आ जाती है. जैसे माइल्ड, मॉडरेट, सीवियर डिजीज डॉक्टर मेहरीन अरशद ने बताया था आपको, आउट पेशेंट फॉलोअप इज वेरी की, क्योंकि माइल्ड से मॉडरेट डिजीज में जाना और मॉडरेट से सीवियर डिजीज में जाना 1-2 दिन की बात होती है. यूजुअली दिस इलनेस टेंड्स टू बी at the end of the first week. If you're going to get worse, that's when things starting worse, क्योंकि initial phase में वायरस replicate कर रहा होता है. जो second phase होता है वहां पे एक सिंड्रोम है जिसको साइटोकाइन स्टॉर्म कहते हैं, जहाँ पे बहुत ज्यादा इन्फ्लेमेशन बॉडी में जनरेट होती है और लंग्स में बहुत ज्यादा हाइपर इम्यून रिस्पॉन्स होता है जिसकी वजह से लंग डैमेज होते हैं, वो लेट होती है डिजीज में। तो अगर आपके पास कोई क्लिनिक में आया है और वो माइल्ड डिजीज है, if they have fevers or a high risk factor or cough or a high risk factor, and they have shortness of breath and their oxygen level is between 90 to 94%, इन लोगों मरीजों को आपको 1-2 दिन में फिर से रिवैल्यूएट कर लेना चाहिए। अगर आपके पास टेली हेल्थ सर्विसेज हैं और आप वो कर सकते हैं और घर पे पल्स ऑक्स है तो दैट इज आइडियल, क्योंकि आपको टेम्परेचर दिखा सकते हैं एंड ऑक्सीजन दिखा सकते हैं। और इसके बाद एक और हम सेशन करेंगे जिसमें वी टॉक अबाउट ऑक्सीजन एंड पल्स ऑक्स मॉनिटरिंग एट होम, जो कि जिन एक्सपर्ट्स के मैंने नाम लिए थे वो में शामिल होंगे इन मोर डिटेल। अगर सिर्फ बुखार है, थोड़ी सी खांसी है और कोई और सेहत के मसले नहीं हैं, तो ये लोग फिर आपके साथ फॉलो अप तब कर सकते हैं जब अगर खुदा न खास्ता इनकी तबीयत खराब हो, एंड दे जस्ट हैव टू कॉल यू एंड let you know if things get worse, and you can decide based on how they're doing to come back to see you. तो यहाँ पे ये moderately ill patient वाला केस आ जाता है, which is where I think the art of medicine comes in, because this is the line between people can stay at home or you should start considering them going to the hospital. I think the most important thing here is that in an ideal world, जहाँ पे आपके पास सारी resources हों, सारे अस्पताल के बेड ओपन हो और ER में आप 5 मिनट में आपको देख लिया जाए, तो all these patients ideally should be evaluated in healthcare facility. लेकिन unfortunately जिस तरह से ये disease दुनिया में फैल रही है, we are kind of battling with a situation where the actual magnitude of the disease is overburdening the healthcare systems. ये सिर्फ पाकिस्तान की बात नहीं है, अमेरिका में भी यही हाल हो रहा है इस वक्त। तो we have to have guidelines for you guys at home कि जो GP है वो इन मरीजों को किस तरह सेफली मॉनिटर कर सकता है हॉस्पिटल के बाहर और अपनी क्लिनिक में। तो if you're following in that moderate illness category, which is a respiratory rate of around greater than 20 and your pulse ox saturation is less than 94, the patient doesn't want to go to the hospital or you don't have space in the hospital, then you definitely need to have pulse oxygen monitoring at home, जैसे हमने अभी mention किया था। And if at any time अगर उनकी oxygen saturation 90% से कम हो रही है और उनका respiratory rate 30 breaths per minute से ज़्यादा हो रहा है, the severe category is met and you should recommend they go to the hospital immediately, ambulance get through. And यहाँ पे we do mention prednisone. And prednisone, steroids in general categorically have not been studied yet in a clinical trial outside the hospital. जो बड़ा ट्रायल आया था वो पब्लिश हुआ था इंग्लैंड से, उसका नाम रिकवरी ट्रायल है, एंड उसमें लोगों को डेक्सामेथासोन मिली थी जिनकी ऑक्सीजन लेवल्स लो थी या वो वेंटिलेटर पे थे, 6 मिलीग्राम बाय माउथ फॉर 10 days, एंड उसमें there was a mortality benefit and people did better. Their outcomes were better when they had respiratory compromise with COVID-19 disease. और हम लोगों की बातचीत होती रहती है जनरल प्रैक्टिशनर से पाकिस्तान में, लोग इस्तेमाल कर रहे हैं स्टेरॉइड। सो इस सिचुएशन में अगर किसी को मॉडरेट इलनेस है और वो हॉस्पिटल में नहीं है और आप उसको ऑक्सीजन दे रहे हैं घर पे, तो वी कैन एक्सट्रैपोलेट द डेटा आउटसाइड द हॉस्पिटल। Because it was 6 milligrams of dexamethasone, and most people don't prescribe dexamethasone in clinic. It's a very high potency steroid. Prednisone is commonly used, and if you convert 6 milligrams of dexamethasone to prednisone, it comes around 38 milligrams. So we suggested 10 milligrams for 10 days. Now, there is a big caveat here. आपको मालूम होना चाहिए, obviously आपका मरीज है, अगर डायबिटीज है तो उनकी शुगर्स जो हैं दे विल स्पाइक, वो ऊपर जाएंगी। अगर इंसुलिन डिपेंडेंट डायबिटीज है तो उनको उनकी इंसुलिन की डोज आपको शायद बढ़ानी हो। सो अगेन ये सिर्फ घर पे इसलिए आपको ऑप्शन हम दे रहे हैं क्योंकि कुछ मरीज ऐसे होंगे जिनको सिर्फ ये बीमारी होगी और उनकी ऑक्सीजन लेवल्स कम होंगी, चाहे उनको हाई रिस्क कंडीशन ना भी हो, तो उनको आप दे सकते हैं ये, लेकिन इन लोगों को फॉलो क्लोजली करना बहुत जरूरी है। फिर इसके बाद देयर इज अनदर टेक्निक कॉल्ड अवेक प्रोनिंग, जो कि अगली स्लाइडों में हम डिसाइड करेंगे। और फिर ऑक्सीजन थेरेपी, ऑब्वियसली अगर आपकी ऑक्सीजन लेवल्स कम हो रही हैं तो और आप हॉस्पिटल नहीं जा सकते तो वो भी घर पे डिलीवर हो सकती है। So basically awake proning in simple terms means कि आप अपने पेट के ऊपर लेट जाएं. Certain people obviously can do that. अगर आपके पास कोई है जिसका C-spine में फ्रैक्चर है, गर्दन का फ्रैक्चर है, कॉलर पहने हुआ है, अगर कोई बहुत ही morbidly obese है, तो अगर वो पेट के बल लेटेगा तो you'll actually suppress the diaphragm from expanding. So again, the clinical scenario where you use this has to be that the patient has hypoxia, कि उनकी ऑक्सीजन लेवल्स लो हैं और उनको सांस लेने में मुश्किल हो रही है. ये सिर्फ उन्हीं लोगों में काम करता है, और यूजुअली एवरी 4 hours दे टेल यू टू चेंज पोजीशंस, कि आप अपने पेट के बल लेटें, साइड के साथ पे लेटें या बैठ जाए. पीठ के ऊपर लेटना या नॉर्मल तरह से लेटना और जस्ट laying flat on your back, actually if it does not give you the benefit of oxygenation that you need, it has to do with matching of ventilation and perfusion in the lungs with COVID-19. So if you can lie on your stomach, that's best. If you can lie on your side, that comes after that. Then sitting up is better, and lying on the back is not preferred if you have low oxygen levels or if you're in respiratory distress. And agli slide mein we'll show you some positionings. The first one is just lying flat on your stomach on the left upper corner in figure 1. Figure 2, you can see the patient's on oxygen while lying on the side with the head turned to the side. Figure 3 is lying on the right side. And then figure 4 is lying on your left side. And you should alternate these positions as mentioned earlier. So when you're talking about oxygen supplementation at home, hypoxemia is usually defined as less than 90% when you're looking at targets. So most healthy adults, आम लोग जो हैं रात को सोते हैं उनकी oxygen saturation 90% तक जा सकती है, and they actually don't have any symptoms from this. We will talk a little bit about this, and it'll get a little complicated when you're talking about people who are who actually breathe better because they're hypoxic, and ये उन लोगों में होता है जो सिगरेटें पीते हैं, जिनको COPD होता है, who have combined hypercapnic respiratory failure in addition to low oxygen levels. In लोगों में, if you give them too much oxygen, that can be actually bad for you. So target oxygen, अगर आप किसी को oxygen दे रहे हैं तो 90 से 90 to 94% should be your goal that you're aiming for to get their oxygen level up. You should not be trying to get them to 99 to 100%. So key recommendations this point पे ये होंगी कि anyone who's getting oxygen should have a pulse oximeter at home. Oxygen saturation should be considered a vital sign, as we mentioned, and you should be used as part of assessing and managing these patients with COVID-19. And usually nasal cannula, so you give oxygen, it is the preferred method of oxygen delivery, and you achieve the right flow rate to get your target oxygen saturation, as we said, of around 90 to 94%. So this was the algorithm I was talking about. So you have, आपके पास एक मरीज है जिसको hypoxia है. So most of the things Dr. Mehreen Arshad talked about, where we were talking about mild, moderate, and severe disease, are actually on the right side of the screen, where they just have low oxygen levels and they do not have high carbon dioxide levels in their blood. They don't have hypercapnic respiratory failure. But say you have a patient who has COPD, who's a smoker, has obesity, hypoventilation syndrome, and that is part of your past medical history, so you know about that patient. In them, the oxygen targets or pulse oximetry targets are lower. So if their oxygen saturation is over 88%, these patients usually do not require supplemental oxygen. Now, this is oversimplification in the sense that if someone is at 88% and they're breathing 30 times a minute, they still have severe disease. So you give them oxygen to make sure that their oxygen saturation stays there and they don't tire out. Similarly, if their oxygen levels are below 88%, this is an emergency. So the last point in this flowgram is make sure there's a hospital transfer. So you have आपको ambulance बुला लेनी चाहिए ताकि वो hospital जाए. लेकिन इस वक्त में you actually give them oxygen whichever way you can. So 4 liters from nasal cannula, 5 to 10 liters per minute with a face mask. And if you cannot get their oxygen levels up, then you put them on a non-rebreather. And oxygen titration should be, should be between 88 to 92% in these people. So you're not aiming for that target of 90 to 94 if they have a condition where they have too much oxygen. Right side जो है algorithm का, अगर 94% से ज़्यादा है आपकी oxygen saturation, you do nothing. 90 to 94% is that moderate illness we talked about. Ideally should be managed in the hospital, but if you can't, you should try to get them oxygen via nasal cannula at home to see. And then if they're less than 90%, these people again, just like the other algorithm, you get them high amounts of oxygen by face mask to stabilize them and send them to the hospital.
And just so you know, हमारे जो next few sessions होंगे वो pulse ox और oxygen therapy की details के ऊपर होंगे. So if you have, this is sort of was a very quick overview. So but future sessions में हम जो हमारे experts हैं वो इसमें ज़्यादा और detail में बात करेंगे. In the thank you Dr. Danish. So I just wanted to take just a few more minutes to talk a little bit about children and pregnant women, because I think ये जो group है patients का हम इनके बारे में ज़्यादा सोचते नहीं हैं, and I just want to make sure कि since आप लोग बच्चे भी देखते हैं, adults भी देखते हैं, pregnant औरतों को भी देखते हैं, so you should think about COVID in these categories as well. So बच्चों के बारे में ये है कि the classic symptoms of fever, cough, shortness of breath, that only occurs in less than 70% of children. ज़्यादातर बच्चे जो हैं compared to like about 90-95% of adults, बच्चों में जो है वो GI symptoms जिस तरह डायरिया हो गया, पेट में दर्द, nausea, vomiting, वो ज़्यादा common होता है. So काफ़ी सारे बच्चे जो हैं at least 30%, or according to some estimates even more, उनमें या तो बहुत माइल्ड डिजीज होती है, इतनी माइल्ड कि आपको सिर्फ लाइक थोड़ा सा रनी नोज होएगा, या फिर जो है वो बिल्कुल भी उनको asymptomatic होते हैं, there's no disease at all. So however, having said that, depending on the country, if you look at all the studies across the world, 2 to 5% of all COVID cases are in less than 18 years old. So it's not कि बच्चों को कोविड नहीं होता या बच्चे जो हैं वो बिल्कुल ही सही रहते हैं, उनको में definitely होता है, but it's less than in adults. So if you look at within the children, but जब उनको होता है, then 5 to 15% of them may require hospitalization. So that's a pretty significant number. So so children, in other words, not only do they get COVID-19, but वो से काफी बीमार भी हो सकते हैं, और especially अगर आप hospital rates देखें तो less than 1 year जो infants होते हैं उनमें ज़्यादा होता है, and that probably related to the fact कि जब वो बच्चे वैसे भी बीमार होते हैं, so they don't feed very well, dehydrate जल्दी हो जाते हैं, so because of that, you just want to be very careful in this younger age group if they get COVID-19. More than 90% of children who are infected with COVID, उनके कोई household member को भी infection होता है. So they might have a parent or a grandparent or somebody else in the house that is positive. Now this data is from the time when schools were closed. So if you remember कि जैसे COVID फैला, across the world, जैसे शहरों में मुल्कों में आया, the first thing people did was close down the school. So that's why a lot of these children did not get infected outside the house, they got infected from their own household members. But जैसे जैसे schools खोल रहे हैं around the world, I think it's very important to keep an eye on this number, because children to children transmission has been reported, and the children can infect other children, they can also infect adults. So जैसे schools खोल रहे हैं, I think I would assume that there would be, and if there is COVID going on in the community, I would assume कि बच्चों की number of children जिनको COVID है वो बढ़ेगा, and I think we just need to be careful about that. उसके बाद then you may have heard of this syndrome called multi-system inflammatory syndrome of children. ये बहुत वैसे तो rare complication है COVID-19 की, typically ये about 4 initial illness के बाद 4 हफ्तों के बाद होता है. It's thought कि this is basically post viral syndrome. So पहले virus होता है, उसके बाद फिर आपकी बॉडी के अपनी इम्यून सिस्टम की वजह से सिम्टम्स होते हैं. इसके MIS-C इसको कहते हैं, और मल्टी सिस्टम इन्फ्लेमेटरी सिंड्रोम. इसके the symptoms and in kids that includes prolonged fever. So it's not just a 24-48 hour का fever. It's fevers can go on for 4, 5, 7, 10 days. उसके बाद, and on top of that, rash भी होता है. It's usually a generalized sort of body rash. And red swollen lips, so lips जो हैं बिल्कुल फूल जाते हैं, लाल रंग के हो जाते हैं, conjunctivitis, आंखें लाल हो जाती हैं, और heart arrhythmias और बहुत शदीद इनको abdominal pain भी होती है. In fact, इतनी शदीद होती है कि कुछ cases, I know मेरे hospital में we had at least one case जिसको पहले हमने appendicitis diagnose किया था, and the child had a whole surgery, और जब उन्होंने surgery करी, जब उनको उसको पेट खोला surgery के दौरान, तो they found out कि the entire intestine was inflamed and not just the appendix. और इसके साथ जो है वो nausea, vomiting, diarrhea भी हो सकता है. अगर आप किसी बच्चे को इस तरह देखें, just be very careful, because ये बच्चे बहुत जल्दी जो है ना, they literally can come. We've had a number of cases in my hospital के जो ER में आते हैं, थोड़े से बीमार होते हैं, बुखार होता है, बट चल कर अंदर आते हैं, और लिटरली विद इन आवर्स जो है ना, ये बहुत जल्दी ICU में होते हैं वेंटिलेटर के ऊपर. So अगर if you see a patient like this, just be careful and monitor them very closely, and please send them to the hospital as soon as possible. और hospital में there are management जो हम करते हैं, उसमें echo involved होता है, heart को देखने के लिए IVIG इस्तेमाल कर सकते हैं, steroids, but that's all in the hospital. And if you see a patient, a child with these symptoms, please send them to the hospital, because they can get very sick very quickly. दूसरा ये है कि प्रेग्नेंट वुमेन, इनिशियली हमने सोचा था कि प्रेग्नेंट वुमेन में को COVID-19 से इतना इफेक्ट नहीं होता, बट मोर रिसेंट डेटा हैज शोन कि इवन दो द डेथ रेट्स ऑफ विद COVID-19 प्रेग्नेंट वुमेन इज नॉट हायर देन आपकी जो जनरल पॉपुलेशन है, but US based data and I think there's more data from other places in the world as well, showed कि pregnant women में disease severity जो है वो definitely ज़्यादा होती है. So in this study they showed कि pregnant women are 50% more likely to be admitted to the ICU and compared to women of this same age लेकिन जो pregnant नहीं है, and 70% more likely to need a ventilator. So clearly if you have a pregnant woman with COVID-19, उनको जो है बहुत क्लोजली मॉनिटर करने की ज़रूरत है जब तक उनके सिम्टम्स ख़त्म नहीं हो जाते, क्योंकि अगेन जो है ये बहुत बीमार हो सकती हैं. उसके बाद अगर कोई हाउस होल्ड, जिस तरह डॉक्टर दानिश ने कहा कि अगर आप कोई पेशेंट है, माइल्ड इलनेस है उसको, और आप उसको होम आइसोलेशन कर रहे हैं, इफ देयर इज अ प्रेग्नेंट वुमन इन दैट हाउस होल्ड, you need to tell them कि that pregnant woman should not come into contact with the person with COVID-19. तो अगर जिस तरह वो खाना बना रही हैं तो खाना बनाएं, लेकिन खाना उनको जाके देने किसी और को देना चाहिए. अगर उनके साथ जो है मतलब उनका कमरा जिस तरह साफ नहीं करें, उनसे जितना दूर रह सकते हैं उनको रहना चाहिए, क्योंकि अगेन प्रेग्नेंट वुमेन जो है अगर वो COVID-19 हो जाती हैं, अगर उनको COVID-19 हो जाता है तो अपने लिए भी उनकी डिजीज सिवियर हो सकती है, और उसके बाद जो फीटस है या जो अनबॉर्न बेबी है उसके लिए भी काफ़ी खतरनाक हो सकता है. एंड देन द अदर जस्ट लास्ट पॉइंट आई वांट टू मेक इज के जिस तरह डॉक्टर दानिश ने टॉक्ड अबाउट ऑक्सीजन थेरेपी एट होम. सो नॉर्मली तो हम जो है वो अगेन, सो इफ समबडी इज गेटिंग, इफ प्रेग्नेंट वुमन इज गेटिंग सिक इनफ कि आप सोच रहे हैं कि भाई इसको इनको ऑक्सीजन की जरूरत है, they need to be in the hospital, because again, like I said, they can get very sick. Their rates of severe illness is higher. So this is a very high risk situation. So they should not be monitored in the house at all. However, अगर जिस तरह बेड नहीं अवेलेबल है या कोई किसी और वजह से जो है घर पे हैं पेशेंट और आप उनको अगर ऑक्सीजन देने की जरूरत पड़ रही है, so you have to make sure that the goal of the oxygen is greater than 94%. So this is different from other adults, as जिस तरह डॉक्टर दानिश ने कहा था, जिसमें आप 90 to 94% का आपका गोल होता है, बट प्रेग्नेंट वुमेन में it has to be 95% or higher, and you have to do that क्योंकि otherwise जो है वो फीटस को और बेबी को जो है वो adequate ऑक्सीजन नहीं डिलीवर होती है. So having so you just again be very careful with pregnant women. So with that, I think we come to the end of the presentation. अगर कोई questions हैं तो.
Thank you everybody. Excellent talk. So we have a number of questions actually, and I think because there's so many questions, we're running out of time. I think we're going to do a speed round. So you only have a minute to answer each of these questions maximum. So let me start. Give me a minute. Some of these I can answer also if you want. So one question is infection control related. use of nebulizers at home, in clinics, and in dispensaries. I think the question, I'll answer this one. The question is, I think, more to do with, is there an infection control risk? So remember, nebulization you can do. There's no issues. It's not an aerosol generating procedure. कोई मसले की बात नहीं है. But there is sharing of oxygen mask. So whenever you're sharing any equipment, make sure you wipe it, regardless COVID versus not COVID, because आपको दूसरे भी जरासीम लग सकते हैं. So you wipe it between patients. Next question. This is for Mehreen. Many people are dropping on routine vaccines. Is it wise, or should this be not? This says condemned, but we shouldn't say condemned. We'll say, should this be avoided?
Yes, this should be avoided absolutely. I think ये बहुत dangerous बात है. मैं dangerous बिल्कुल word use करूँगी कि हमारी जो rates of vaccination है बच्चों में, that is going down, and it is very unfortunate क्योंकि COVID-19 बच्चों को होता है लेकिन ज़्यादातर mild disease होता है. So what you really don't want to happen is कि COVID-19 से तो बच्चे बच गए, but उनको जो है वो बाकी जो vaccine preventable diseases हैं, which includes pneumonia and आपका जो बाकी measles, mumps, इतनी सारी और चीजें हैं, और उनके जो है वो rates, especially polio पाकिस्तान में, it is very dangerous, and I'm very happy to hear that that's a question that is raised. But it is please, if you see a patient, they should be, there is no reason to reduce vaccination or to not vaccinate a child in this COVID era.
Thank you. Danish, this one's for you. Home sample collection and its importance in disease management.
So, actually, ये मैंने पाकिस्तान में ज़्यादा सुना है कि हो रहा है, यहाँ पे तो कहीं पे भी ये नहीं हो रहा है. तो I was actually quite impressed कि घर पे लोग आके आपके टेस्ट कर रहे हैं. Sample collection is, knowing how to collect the sample, I think, is the key. क्योंकि जो PCR है, it was validated with a nasopharyngeal swab. So, if I show you, if you put the swab in, it should actually go and touch your nasopharynx in the back. So जब मैं लोगों से पूछता हूँ कि जब आपका swab किया था तो क्या आपको लगा, महसूस हुआ था कि आपके दिमाग को टच किया किसी ने? अगर if you do not collect the swab correctly, even if it is the PCR, your yield will go down, your test positivity rate will go down. But definitely, the more testing that's available, the more people you test, the better you'll be able to get data. So at home, I think it's reasonable.
And also, I think the other thing which is important is कि यहाँ पे बहुत सारे लोग labs, दूसरे भी labs आके घर पे check कर सकते हैं, CBC, ferritin, LDH वगैरह. And I think it's a good idea because जितना कम suffer करें somebody who's in isolation, जितना बाहर वो कम जाए उतना बेहतर. All right, so this one is for any of us. Use of anticoagulation therapy at home. Any pros or cons? Okay, I'll start this then. So anybody with moderate disease, किसी को भी moderate disease हो, so we recommend that they should be on enoxaparin, and इसको लगाना मुश्किल नहीं होता. Remember, the other thing which is very useful over here is there's a lot of home health care. A lot of nurses will come at home, and अक्सर मैंने patients को बताया कि आप सीख लें कैसे लगाना, आप खुद भी लगा सकते हैं, किसी लगवा सकते हैं. The cons obviously इसको करना मुश्किल होता है. And अगर आपको हल्का सा भी शक हो कि ये पेशेंट को ब्लीडिंग का चांस बढ़ गया है, अगर वो कहता है बलगम में खून आ रहा है या पखाने में खून देखा है या कोई ज़ईफ शख्स है जो कि गिर गया हो एंड आपको डर है कि सर पे चोट लगी हो, तो उन केसेस में then you should avoid. The risk is more कि bleeding होगी as opposed to the benefit.
And Dr. Faisal, just to clarify, this is not for mild disease, right? This is for moderate.
Yes, this is for moderate disease. Only for moderate. जिनको ऑक्सीजन दे रहे हैं, उनको आपको ये inoxaparin भी देने की जरूरत है. एक सवाल, I guess, Mehreen, asymptomatic patients, should they be staying at home?
That's a good question. So if you look at the guidelines, the answer should be yes. कि अगर जिस तरह आपका contact है, कोई positive contact है और कोई symptoms नहीं है, you do want to stay. The guideline is कि आप जो है वो घर पे 14 दिन तक जो है वो isolate होएं और अपने symptoms monitor करें. Having said that, I think reality sometimes ये होती है कि the patient, especially if it's somebody who's like earning for the house, has to get out of the house. if that has to happen, you just want to make sure कि वो उन्होंने मास्क सही से पहना हुआ है, वो सारे अपने जो hand hygiene precautions जो हैं वो सारे ले रहे हैं. But the better thing to do and what is recommended is कि घर पे isolate होएं, even asymptomatic patients for 14 days after the contact with the COVID-19 patient.
So here I'll just clarify also, Dr. Mehreen बात करी उन लोगों का जिनको बीमारी लगी नहीं है मगर वो एक्सपोज में हैं. So obviously वो तो जा सकते हैं बाहर, but with proper precautions. But वो लोग जिनको बीमारी लग चुकी है and उनको symptoms नहीं है, they still need to stay at home. वो बाहर नहीं जा सकते, unfortunately. And इसी तरह से there was a question on treatment protocol for asymptomatic patients and pre-symptomatic patients. And इसके लिए there's no treatment. मतलब आपकी तबीयत ठीक है तो आप छोड़ दें, बस दुआ करें कि symptoms develop ना हो, and ज़्यादा लोगों में नहीं होती. Danish, for you, some patient in close relatives is PCR positive for 2 months. No symptoms, advice for job continuity.
So this is unfortunately a very common scenario. So what I'm explaining to people is that the guidelines for isolating people are either symptom-based or test-based. If you're in a high-risk environment, say you're a healthcare provider, doctor या मरीज देख रहे हैं, तो a lot of your employers are asking for 2 negative PCRs. But all of this comes from CDC, who based their guidelines as evidence shows up. Having the RNA positive for 2 months, I can guarantee that the patient is not infectious for 2 months. You're detecting dead RNA in someone's nose. हर एक की नाक गंदी होती है, किसी की नाक साफ नहीं होती, तो you cannot sterilize a nose. So yes, I feel like this is an unrealistic expectation for that long to get a negative RNA. Honestly, if someone's gone 14 days and they don't have symptoms, I think it is safe for them to return back to work. And we have almost 200 doctors and offices that we supervise. We have instituted that now because the test turnaround time in very high volume areas is almost 7 days here. So लोगों की तो 21 दिन की quarantine तो वैसे ही हो जाती है यहाँ पे, तो I really don't think that is feasible in the long run, and even here the recommendations are changing as we speak.
So यहाँ पे एक अच्छी बात है, हमारा test turnaround time is not एक हफ्ता, it's usually 1 day or less, or sometimes अभी 2 या 3 दिन depend आपने कहाँ पे भेजा है. And वही बात exactly, Danish, and there's other questions regarding this, कि आपके symptom, आपके isolation जो है वो symptom की बुनियाद पे आप discontinue करते हैं, and test की बुनियाद पे नहीं. And patients को मैं समझाता हूँ कि बीमारी खत्म हो जाती है, test में आता रहता है, उसकी फिक्र ना करें. So one other question which is sort of interesting, and I'm going to answer this one, is seroconversion to negative antibody test can rule out disease completely, yes or no? And the reason I'm going to pick this up is because यहाँ पे पाकिस्तान में antibody test बहुत common हो गया. Please याद रखें कि antibody test आपको ये नहीं बताता कि आप इस बीमारी से के खिलाफ आपने ये ताकत पैदा कर ली है कि इससे आप डर सकें. Antibody test ये नहीं बताता कि फ्यूचर में आपको लगेगा कि नहीं लगेगा. And ये मैंने बहुत देखा है कि लोग एंटीबॉडी टेस्ट कराते हैं बीमारी होने के बाद भी, और फिर जब एंटीबॉडी पॉजिटिव आता है तो वो समझते हैं कि बस अब आगे उनको नहीं लगेगा. So another question इसी तरह से कि रीइंफेक्शन होता है कि नहीं होता. So at this point we don't know कि रीइंफेक्शन होता है कि नहीं होता, यानी कि दोबारा बीमारी लग सकती कि नहीं लग सकती. चाहे आपका एंटीबॉडी पॉजिटिव हो चाहे एंटीबॉडी नेगेटिव हो, आपको बीमारी के बाद वही एहतियात करनी है जो कि पहले आप कर रहे थे, which is मास्क पहनना, लोगों से दूर रहना, अपने हाथ साफ रखना. Right? So that's simple. For Danish, I think. Phones has pulse oximetry options. Are these reliable?
So there can I miss phones
के वजह pulse ox का जो option होता है, can we use those?
I don't think that has ever been validated in a scientific study. I would not use this.
And I would just add कि like Apple Watch and Samsung की जो smart watches, and they have the same function sometimes, and again it's not validated to yeah, so I wouldn't use it.
एक मैंने study देखी थी, उसमें it showed कि unreliable है. So
right.
अच्छा, one question which if it's okay with you I'll answer because वो थोड़ा सा local है, कि the main differences between typhoid and abdominal symptoms of COVID-19. तो देखिए typhoid के अंदर बुखार होता है. So अगर किसी को सिर्फ पेट में दर्द हो तो don't think of typhoid. कोविड में बुखार होता है, मगर रिमेंबर टाइफाइड का बुखार थोड़ा लंबा से चलता है, कोविड का बुखार थोड़ा इतना लंबा सा नहीं चलता. कोविड का बुखार तेज भी हो सकता है, हल्का भी हो सकता है, मगर उससे पेट में दर्द बहुत प्रोमिनेंट नहीं होता. सो दोनों में फर्क करना मुश्किल होता है, स्पेशली आजकल के सीजन में जब टाइफाइड का सीजन हमें हमारा शुरू हो चुका है, अपने ऑलमोस्ट अरूज पे पहुंच गए. So ideally if you suspect typhoid COVID तो आप कोविड का टेस्ट करा लें, उसकी रिपोर्ट जल्दी आती है. ब्लड कल्चर ऑब्वियसली करा लें, and exactly as डॉक्टर मेरीन ने बोला कि एंटीबायोटिक्स से गुरेज करें unless you really think कि this is so this is for Mehreen कि vitamin D3 role in immunity for COVID.
There's no good data to suggest that it works. I think vitamin D जो है in general has thought to be associated, low vitamin D has thought to be associated with low immunity. However, COVID-19 specifically जो है there's no data to suggest कि अगर आप vitamin D for example लें तो आपकी immunity बढ़ जाएगी and COVID-19 से आप बच जाएंगे. I mean if you want to take it, लेकिन don't think कि कि आपको COVID-19 नहीं होएगा.
Danish, आपके लिए risks of missing emergency cases, MI, stroke, appendicitis, because of home management.
Yes, that is a reality. Actually, here people stopped going to the hospital because they were so scared they were going to catch COVID-19 in the hospital that people started having strokes and heart attacks at home. So yes, and that is why close outpatient follow-up is what we are recommending. If we वही बात है कि हमने जो कहा है कि moderate disease should be managed in the hospital. That is why आप anticoagulation की घर पे बात कर रहे हैं कि anticoagulation घर पे इसलिए दिया जा रहा है because COVID-19 patients are more prothrombotic. The young people are dying of strokes and heart attacks after COVID. So yes, it is a reality, but again, if you have no choice and you have to deal with the patient outside the hospital, then Lovenox is a good way of dealing with it.
So इसी तरह का एक सवाल, I guess it's a very quick one कि should we add PPIs या anti-acids and in home based care is for sedentary living and stress ulcer prophylaxis. So I would not give PPIs in somebody unless आप उनको कोई दवाई दे रहे हैं, which unless you give them anticoagulation या steroid दे रहे हैं. अगर वो नहीं दे रहे तो PPI ना दें. याद रखिए PPI के अपने नुकसानात भी होते हैं. So there's no role of PPI in those cases. And another question which again I'll answer very simple is can DVT be a sign of COVID? So COVID के अंदर आपकी hypercoagulability होती है, DVT हो सकता है, but याद रखिए it's a late manifestation. So about 3 weeks into the disease is when you see hypercoagulability. So just a DVT by itself, आप उसको सिर्फ COVID पे ना छोड़ें, do आपका अपना DVT का workup जो है. Mehreen, risk of children 2 to 5 to be affected during the COVID positive parents during home isolation. So I think home isolation में अगर छोटे बच्चे हैं उनको नहीं है मगर parents को है तो क्या किया जाए, and vice versa.
Yeah, I mean, I think job general hand hygiene is very important. I think it's trying to stay away from the children as much as possible. Basically, अगर आप जिस तरह आपको नज़ला ज़ुकाम होता है और आप बच्चों से दूर रहते हैं ताकि बच्चे ना बीमार होएं, you have to basically do the same thing. And vice versa भी अगर बच्चे जो हैं वो बीमार हैं, उनसे जो है ये नहीं कि आप उनको बिल्कुल neglect कर दें, खाना ना दें, all that stuff. Take care of them, but ये है कि make sure कि आपके हाथ जो है ना हाथ धोए हुए हैं and हाथ धोएं and if there is a pregnant mother, तो ये बहुत होता है young families में कि there's mother's pregnant, बच्चा जो है वो बीमार हो गया, the mother herself is fine, she can always wear a mask inside the home when coming into close contact with children.
So in other words, if you have a young child who has COVID and the kid cannot be separated from the mother, then the mother can wear, or the father, whoever the healthiest of the two is, can wear PPE and take care of the child.
Right.
एक और सवाल आपके लिए Mehreen, अब now we have to be even faster. Kawasaki disease differentials with COVID.
So Kawasaki disease Kawasaki's disease and your MIS-C that I just mentioned, multi-system inflammatory condition in children, उनके जो overlapping features काफी होते हैं, and so Kawasaki's disease is a little different because it tends to happen in younger age group, from 1 to 5 का जो age group है, toddler age group जो होता है, whereas जो post COVID related जो post inflammatory syndrome है, that tends to happen in a little bit older kids, so the median age, most of those children are more than 5 years of age, and they can include teenagers as well. In Kawasaki disease में abdominal pain इतना ज़्यादा severe नहीं होता. बाकी जो है fevers भी हो सकता है, rash भी हो सकता है, lymph node, the lip swelling and all, conjunctivitis वो सारा हो सकता है in KD. लेकिन MIS-C में the way to differentiate post-COVID inflammatory syndrome and KD is basically age. Okay, the older age group tends to get the more of a post-COVID, and secondly is abdominal pain, because abdominal pain tends to be more severe in children in the post-COVID inflammatory syndrome.
Danish, questions similar together, and then the last couple I'll just answer myself. एक सवाल ये है कि what about home oxygen in people who have COPD, because that may cause hypercapnia, and the other question इसी तरह का कि अगर आप फिर भी short of breath हो और 96% saturation आ रही है तो फिर क्या किया जाए?
So पहला सवाल जो COPD का है, इसीलिए that's why we added that part to the algorithm. कि if someone has COPD, your target O2 sat should be over 88%. You should not be actually giving them oxygen, and you should keep them below 94%. You're not aiming really high. So if you have someone with hypercapnia, you want to, if their oxygen saturation drops below 88, that's when your trigger goes in to give them oxygen. But you don't give them, you don't put a hypercapnic patient on a non-breather, because you're going to take their respiratory drive away. They'll stop breathing. So that has to be done carefully. और होते हैं COPD patients बहुत commonly actually होते हैं घर पे oxygen पे, but it's learning how to deal with it. Venti masks का role आ जाता है that you can control the exact percentage at home as to how much they get, and they don't get more than a certain percentage no matter how much they dial it up. So that is why we included that specifically for COPD patients. So 88% I guess is the magic number, and not to go over 94% when you're correcting their oxygen with whatever 80 goes. And your second question was oxygen saturation. I missed the second part. What was the second?
Breath or oxygen saturation ठीक आ रही हो.
So respiratory rate alone meets criteria. So people tire out. If you have someone breathing 30 to 40 times a minute with an oxygen saturation of 95, 96%, that is the same as if their oxygen saturation is low, because if you can't slow their respiratory rate down, they'll get respiratory muscle fatigue and they will crash on you. So respiratory rate alone can be used as a criteria to decide if someone needs supplemental oxygen. So you can keep their oxygen saturation at the same level, even if they're at 96, 97%, but you should be able to bring their respiratory rate down.
Good. So there are a couple of very similar questions. So मैं एक साथ उनका जवाब देता हूँ. Again, infection control wise. तो पहला सवाल is के masks के बारे में कि जो cloth masks बिक रहे हैं, क्या वो इस्तेमाल कर सकते हैं कि नहीं कर सकते, उसमें क्या देखने की जरूरत है. So दो तीन चीजें, अगर remember healthcare setting के अंदर you have to wear a surgical mask, मगर आप अपने patients को बोल सकते हैं जब बाहर घूम रहे हो, because everybody should be wearing mask. A cloth mask is okay. उसमें क्या देखने की जरूरत है, बस देख लें मोटा कपड़ा हो एंड उसको पहनने से पहले धो लें घर पे आके गर्म पानी के साथ और साबुन के साथ, because we don't know कि बाहर किसने पहना हुआ वो मास्क. Eid advice, lots of Eid advices are coming up, and remember Eid is going to be difficult for us. इसमें दो तीन चीजें हैं. एक तो बकरा मंडी और बकरा गाय खरीदने के लिए अगर आपके पेशेंट्स के पास ये सहूलत है कि वो ऑनलाइन खरीदें तो वो ऑनलाइन खरीद सकते हैं, but this I know is not possible for majority of people. So उसके अलावा SOPs तैयार किए गए हैं गवर्नमेंट की तरफ से, and I think the pretty good SOPs. उसमें जो मेन 3-4 पॉइंट्स ये हैं कि प्लीज जो भी जाए बकरा या गाय लेने के लिए तो घर में से सिर्फ एक अफराद जाए, चाहे तो एक बंदा अपने भाइयों का भी साथ खरीद में ताकि रश कम से कम हो. मास्क पहने रखना है, हाथ साफ रखना है, एंड याद रखें कि ये हमारा कॉन्गो का सीजन भी है. सो ये आप पेशेंट से बोलेंगे कॉन्गो के एहतियात भी करनी है, जिसका मतलब है कि वो कपड़े ऐसे पहने जो कि हल्के रंग के हो, फुल स्लीव हो, मोजे पहने और घर आके अपना चेक कर लें टिक वगैरह तो नहीं है. जब आप गोश्त बांटने जाएं तो मेक श्योर कि मास्क पहने रहें, गले ना मिलें, वेरी इंपॉर्टेंट. एंड देन ऑब्वियसली बहुत कोशिश करें कि दावत ना करें और दावत में जाए भी ना, both ways. इस लास्ट ईद में हमने बहुत खानदान देखे जिनके अंदर दावतों की वजह से लोगों को वायरस भी लगा और खानदान के 2, 3, 4 अफराद की अमवात भी हुई। तो इवन अगर आपके खानदान में किसी को या किसी भी खानदान में कोविड हो भी चुका है पिछले ईद, तो इस ईद में भी प्लीज दावत में ना जाए। एंड कुछ सवाल थे कि अगर अकेले हैं तो मास्क पहनने की जरूरत है कि नहीं, ड्राइव करें तो जरूरत है कि नहीं, तो नहीं, आप मास्क उतार सकते हैं, बट ख्याल रखिएगा मास्क का बैरूनी हिस्सा, बाहर का हिस्सा गंदा होता है, उसके बाद हाथ साफ करने की जरूरत है, और अंदर का हिस्सा भी गंदा होता है क्योंकि उसके अंदर आपके सिक्रेशन होते हैं, तो हाथ साफ रखने की जरूरत है। And I think that's it. These were the questions that were passed on to me. I think और भी सवाल हैं, मगर just to sum up then, Mehreen and Danish, if you would allow me, I think the talk was that they were very well done, and I think इसमें 2-3 important key points अगर याद रखने की जरूरत है वो ये कि घर पे पेशेंट्स की आइसोलेशन कैसे करनी है, जो डॉक्टर मेरी ने अच्छी तरह बताया, उनको अलग रखना है एंड ख्याल रखना है। The other is याद रखिए कि स्टीरॉइड्स का यूज वेरी इंपॉर्टेंट सिर्फ उनके अंदर है जिनके अंदर ऑक्सीजन की कमी हो रही है, बल्कि दानिश ने आई थिंक ये मुझसे मिस हो गया होगा, या जो स्टडी थी जिसमें स्टीरॉइड्स का इस्तेमाल किया गया था उन लोगों में जिनके अंदर ऑक्सीजन की जरूरत नहीं थी, उनके अंदर एक्चुअली मोर्टेलिटी थोड़ी सी खराब थी। स्टीरॉइड ने एक्चुअली चीजें खराब की थी, बेहतर नहीं की थी। और इसी तरह से दूसरी दवाइयां जैसे कि रेमडेसिविर हो गई, जो एंटीवायरल्स हैं वो भी घर पे लेने की जरूरत नहीं है, वो सिर्फ उन लोगों के लिए है जिनके अंदर मॉडरेट डिजीज है, जिनकी तबीयत खराब हो। अजिथ्रोमाइसिन जो एंटीबायोटिक है उसका कोई रोल नहीं है। आई थिंक मेरे पास बहुत ही कम ऐसे मरीज आए जिनको एंटीबायोटिक नहीं दी गई हो उनकी जीपीस की तरफ से कोविड के साथ साथ। प्लीज इस्तेमाल ना करें, ये हमारी वाहिद दवाई रह गई है टाइफाइड के लिए, और ये ना हो कि अगले साल हम लोग टाइफाइड से मरना शुरू हो जाएं, मगर कोविड से बच गए, मगर कोविड में तो जरूरत ही नहीं होती। And I think Mehreen, Danish, any single 2-3 liners that you want to say, which I may have missed in the summary?
Yeah, I think from my perspective, just बिल्कुल नहीं, मास्क पहने और and everywhere, and honestly I think यहाँ पे there is a lot of debate कि बच्चे नहीं मास्क पहन सकते हैं, और बच्चे मास्क पहन सकते हैं। Anybody who's older than 2 years old can wear a mask. If the parents are wearing a mask, बेसिकली आपको उनको बोलना होता है। अगर आप उनको कोई ऑप्शन नहीं दें कि भाई अपने कपड़े भी तो पहनते हैं ना बच्चे, तो अगर आप उनको ऑप्शन नहीं दें कि भाई आपने मास्क पहनना है, तो बच्चे पहनते हैं, कोई वो उस तरह का कोई मसला नहीं होता। सो एग्जैक्टली मास्क पहने, एंड अगेन एंटीबायोटिक्स, आई थिंक बहुत ज्यादा ओवर यूज होती है एंटीबायोटिक्स इन वायरल इन्फेक्शंस, सो आई थिंक जस्ट मेक श्योर के अवॉइड दैट।
Okay, thank you very much for being with us, and have a good weekend. Khudafis.
Khudafis.